Hi there, I'm Dr. Kate Gifford, and in this lecture in our advanced stream of the online seminar series for Myopia Action Month, I'd like to take you through new technologies in myopia control. Now, we have had numerous treatments, numerous interventions for myopia control which have been studied, and what I'm going to do just over the next 15 minutes is briefly take you through an understanding of how some of these treatments are similar and how they're different in terms of our new spectacle lens designs, contact lens designs for myopia control, the newest data on 0.01% atropine. There's been a lot of recent studies on that. And then also perhaps one of the most interesting and even controversial therapies which has emerged recently, which is red light therapy. So let's get started. We will start with the latest on spectacle and contact lens technologies for myopia control. Now, firstly, what I'd like to do is bring together some theories of defocus in myopia to help you understand the similarities across our optical treatments for myopia control. On the left of the slide, I'm just going to put up a little example of peripheral defocus. Now, what we've got there is a model eye, so that's the oval part of the image. And then in front of that, imagine that we have a center distance multifocal or an orthokeratology topography treatment in section. So in either of these modalities of contact lens wear, we understand that the central rays will pass through and hit the retina. We've got essentially our single vision distance correction through the central portion of the lens or of the topography. And then the mid-peripheral steepened zone of ortho-K or the mid-peripheral ad zone of a multifocal soft contact lens provide myopic defocus. So the rays which are passing through those red zones, the ad zones, fall in front of the retina to create myopic defocus. But this also happens on axis as well, and it's important for us to remember in the case of a center distance multifocal or ortho-K that we get on axis myopic defocus as well. And this is an image here on the right of spherical aberration where we have peripheral rays focusing more myopically than central rays. And we can't separate these elements out. These optical elements are all happening within the eye at the same time. Now we can sort of imagine these brought together in the concept of simultaneous defocus, and I think we can picture this most easily as a dual focus soft contact lens or the MySight One Day, where we have alternating zones of distance correction and the ad zone, which is a 2-ad in the MySight, creating myopic defocus. And where things are moving now with spectacle technology and contact lens technology as well is pushing this concept of simultaneous defocus further into where's the location of the defocus, what volume of defocus do we have, is it spherical or aspheric, and what pattern of defocus are we achieving as well. Now for a little journey through our optical technologies for myopia control and how, as I see it, our spectacle lenses have inspired contact lenses which have inspired spectacle lenses again. Now on the left of the slide you can see our original spectacle lens designs investigated for myopia control, bifocal and progressive edition spectacle lenses. Research published over 10 years ago found that it might be in fact more the large area of peripheral defocus created by the ad zones of these lenses that was more closely correlated with the myopia control effect than perhaps the other impacts these lenses have on the visual system, namely altering accommodation and binocular vision. Now think about the advent of our soft contact lens myopia studies. These were first done in presbyopic designs, so multifocal contact lenses, designs that were originally developed for presbyopia. And the technology has developed a lot since, which I'll tell you a little bit more about in a couple more slides' time. Now I really see our new generation of myopia controlling spectacles, which you can see there on the right of the slide, as taking inspiration from contact lenses. So contact lenses have the advantage of being able to move with the eye and to cast a constant and consistent pattern of optical defocus on the back of the eye, regardless of the directions of gaze. And I really think this is what we're seeing achieved now with our new generation of myopia controlling spectacles. Now they have significant differences in how they do this, in how they create simultaneous defocus, in the level of defocus using spherical or aspherical lenslets or diffusion technology, or even employing changes to higher order aberrations rather than defocus itself. But along with that, there are some similarities between these, and I hope that this sort of helps you put them together in your head in thinking about how they function for slowing myopia progression. Now, there's definitely some similarities amongst these designs. The similarities are they all have a clear central aperture with the single vision distance correction, and that might be for lens verification as much as for distance vision. They all have a surrounding treatment zone, however that may be configured to employ the myopia control effect. And they all have a single vision background across the entire lens. Now, maybe there's spaces within the treatment zone to see that background single vision. Maybe there is not in the case of the diffusion optics technology. What's also really interesting is that these are not add powers. These lenslets are not creating an add in the orthoptic sense. So the research that we have in these designs so far indicates that they do not alter accommodation or binocular vision function as we would expect out of a progressive addition or bifocal spectacle lens. Now, we also have a variety of contact lens technologies which have been investigated and developed for myopia control as well. And I just want to point out to you some differences between these various designs, just as I have for the spectacle lenses. Now, we have an extended depth of focus design, which has been more specifically engineered to incorporate higher order aberrations to modulate retinal image quality. So different to creating concentric dual focus areas of focus and then myopic defocus. In the middle there, we've got our center distance multifocal with a 250 add, which is also used for presbyopia but has been researched and shown to be successful for myopia control. And then we have some newer kids on the block in terms of the research on the right of the slide. Now, the second last lens is a non-coaxial ring focus lens with very high levels of add power. And this is described in its paper as rays passing through a concentric annular zones of the prototype lens, which form a ring focus in front of the retina. So this is thinking differently about the location of the defocus, but still creating that defocus. And finally, the quaternary optics is described as having a rapid transition and smooth transition to a high relative plus power away from the lens center and creating a significant depth of focus effect as well. So in all of these cases, we have similarities of them being center distance, and we all have these treatment zones which are surrounding the center distance zone, same as for our spectacle lenses, but they are employing the treatment zone, employing this defocus, which will occur on and off axis in various ways. Now, you might be thinking, well, which works best? And thus far, the evidence seems to indicate, although there's different levels of evidence for these different interventions, that a lot of these treatments work quite similarly. I'd like to point you towards 2 articles for you to learn more, and also in the foundation stream of the online seminar series of Myopia Action Month, I've done a whole lecture on understanding efficacy. So jump over to that one if you want to understand a little bit more about various ways we can explore and understand and compare treatments for myopia control. So there's an article on myopiaprofile.com called Which Treatment Works Best? And this is something which helps you to understand different ways we can categorize treatments and compare them. And then the article on the right is very recently published in My Vision, which is an Australia and New Zealand ophthalmic journal. This was written by myself and my Myopia Profile colleague Jeannie Saw, where we go through 5 different ways to understand myopia control efficacy. We also give you what this means from a clinical perspective and what the numbers are likely to show you. Because from our science nerd point of view, we're very interested in understanding and comparing treatments, and there's more and more we're learning about that with time. Now, regardless of the treatment which is chosen, which will be chosen based on what's available to you and what best suits the patient, the message is clear across the studies that full-time wear is of utmost importance. All of these figures here on the slide show us the level of average wearing time that was found in these specific studies, indicating we really want to match that if we're going to achieve the same levels of robust efficacy we've seen in these studies. And in the highly aspherical lenslet spectacle lens study, which is the top left image there, they found specifically that children who wore their spectacles for at least 12 hours a day, 7 days a week, had the best results. So full-time wear is going to help us achieve the best efficacy of any of these treatments. Now I'd like to take you through the latest on low-dose atropine. And I want to take you through this because there has been a lot of recent research on 0.01% atropine. And from our initial understanding of 0.01%, when it was compared to 0.05 and 0.025% in the LAMP study, 0.01% as a monotherapy appeared to have very modest, very minimal effects for slowing myopia progression. We've had a raft of new studies published in the last year, and all of these green numbers show us the durations of these randomized controlled trials. We'd never had anything longer than 1 year comparing different efficacies before, which was the LAMP study. It was 1 year placebo controlled. But now we've had 2 and 3 year studies published on 0.01%, and one also included 0.02%, and also interestingly exploring different populations outside of East Asia where a lot of the studies have been done. So what are the results? Well, what I'm going to do here in this slide is show you what the absolute myopia control effects were of the 0.01% compared to the treatment group. And then we're going to compare these to a couple of optical treatments for you to get some context. So there are a variety of atropine studies which have been published. They all have nifty acronyms. You have to have a nifty acronym for your atropine study. What I want you to look at is firstly in those blue boxes down the bottom, the durations of the study. And underneath that, the amount of millimeters of control, so millimeters of myopia control effect, less progression compared to the treatment group. Now in that little red bubble up in the top left hand corner, we can see that one goal, one judgment that we can use to look at efficacy, and I've explored this further in the efficacy lecture in the foundations stream, is 0.1 millimeters per year. If we're slowing eye growth by 0.1 millimeters per year or more, we're moving eye growth from that speedier myopic level of eye growth back to that slower emmetropic level of eye growth. So if you divide the millimeters by the years, if any of those are over 0.1, then we're likely achieving a fairly robust myopia control effect. But what you can see is they're not. And any of the numbers there that have a cross beside them indicates that they weren't statistically significantly different. There's no difference found on the analysis between treatment and control group. At the bottom of the blue boxes are the diopters of control. And what I really want to point out to you there is that they vary quite wildly compared to the millimeters of control. And that's why millimeters is our far more accurate judge, our finer measurement ruler for understanding myopia control efficacy. Now next to this, I'm going to put up the 1 year and the 2 year data for our first myopia control specific design soft contact lens, the dual focus MySight, and then our first to be published myopia control spectacle lens, which is the defocus incorporated multiple segment, or the Hoya MyoSmart. Now have a look at the 1 year and 2 year data in terms of the millimeters of control. In each case, you can see that it's jumping that hurdle of slowing progression by at least 0.1 millimeters per year. Now we can't say that these are different to the atropine studies because we haven't compared them directly. Doing that is statistically tricky, but it's possible. It's most accurate to do it in a direct study. But you can see that there appears to be some differences. None of these atropine results seem to be quite as strong as the results we've seen with spectacle and contact lens interventions. But something we're really starting to learn from this new raft of myopia control studies is who the ideal candidates might be for 0.01% atropine. And as I said, what's unique about these studies is that they have taken place in children outside of East Asia. So in populations in North America, in Australia, in Europe, which have enabled us to see who the best candidates might potentially be for 0.01% atropine. Now, this is the Mosaic study, which is undertaken in Ireland with around 80 to 85% children of white ethnicity. And what they found is that in the children of white ethnicity, there was a significant effect over 2 years. So the 2-year data under the little bottle there on the left is the overall cohort data, but the 2-year data for the children who had blue eyes actually found a significant effect and a more impressive effect overall. The chart on the right there shows that there were significant differences in atropine 0.01% treatment over 2 years for children of white ethnicity, but not for children of non-white ethnicity. Now, this study also delved further and found that in children who were aged 11 to 16 in their study, there was also a fairly impressive and significant effect over 2 years. Still maybe perhaps not as much as what we'd seen in those optical treatments, but again, we're not comparing those directly. Most fascinatingly, this study was impacted by COVID lockdowns, and they found that children who had suffered the least from COVID lockdowns, so they'd been recruited after the most significant periods of lockdown, had an even greater effect. So this study was impacted by COVID, as some of our most recent myopia control studies are, and that shows the impact of more indoor time, more screen time potentially, really zeroing out the myopia control effect of a treatment. Now, on this theme, there was a study undertaken in Australia, in Western Australia, so about 4 or 5 hours flight away from where I am right now, which looked at a cohort of children who are around 60% of European ethnicity. And what they found is that in the overall cohort over 2 years, there was no significant effect of 0.01% atropine, but actually it was significant at 1 year. So look at those results there over 1 year. That's quite a reasonable amount. That's even getting close to that 0.1 millimeter hurdle that we sort of put in place as a judgment of myopia control efficacy. Now, analysis by eye color didn't find any differences, but analysis by ethnicity found that there was a significant effect for kids of European or mixed ethnicity. That's hard to say, mixed ethnicity. But for children of East Asian or South Asian ethnicity, there was no significant effect. And this tells us that the clinical utility of 0.01% might be for kids with blue eyes, of white or European ethnicity, maybe for older children as well, although it's important to note that two other large-scale atropine studies, which were undertaken in North America, the PEDIG and the CHAMP study, found no influence of iris colour on the myopia control effect. There is a lot of research, though, to show the combination of 0.01% with ortho-K is quite powerful, at least in the short term, to boost efficacy. And other optical treatments are just starting to emerge in terms of this combination research. There might be a benefit of combination with the dim spectacles. There may be a benefit of combination with MySight One Day, although both of those studies were limited in terms of their ability to measure these differences. And there has been a study on the center distance multifocal with a 250 ad, which found no boosted effect by adding 0.01% atropine. So there's some definite benefits there to 0.01% in combination, and in us understanding specific candidates where it could be a very suitable treatment for them, particularly if you have myopia controlling spectacles or contact lenses that are not available or suitable for those patients. Finally, I want to touch on red light treatment. Now, this is a fascinating new treatment which has come out of China, out of an instrument which was originally designed and developed for amblyopia treatment. And essentially this involves spending 3 minutes twice per day, separated by at least 4 hours, 5 days per week, looking into this instrument which emits 650 nanometer red light. It's essentially designed as an alternative to the bright light that we would get from spending time outdoors, which is a little depressing that the children are not spending the time outdoors, but, obviously sensible in various environments, particularly urban environments where perhaps it may not be specifically as easy to achieve. And this has been classified by the international standards as a Class 1 laser safe for direct ocular exposure. Now, the red light treatment for myopia study had a randomized controlled trial for 1 year, and then they had some crossover and dropout in smaller groups over 2 years. But in the first year, there was a very impressive myopia control effect. Looking at percentages there, you can see on the left, and millimeters, quite strong effects of the treatment group compared to the control group. In the second study, they had a cohort continue on the red light treatment and a cohort continue in single vision, and there was again a really clear benefit of the red light treatment in terms of slowing myopia progression. But they also had a group who ceased the red light treatment and went back to single vision correction, and this group had a significant rebound. Their eyes grew 0.42 millimeters in a year compared to 0.28 millimeters for the kids who'd stayed on single vision. Now, a rebound effect is concerning, and that perhaps tells us something about ensuring how this treatment would be tapered or at when it would be ceased, that the children are old enough and their myopia is stable enough to cease the treatment. What's made this a real red hot topic in myopia control is these two sort of conflicting elements of axial length shortening, which has been measured in around 15% of kids, 2.1 millimeters or more over the short term. Now, there's also even more kids who are showing shortening or stability within 0.05 millimeters. That can be within the range of measurement of an axial length instrument. So for me, at least, this data of 0.1 millimeters or more shortening or lesser axial length is very impressive stuff. But there was also a very highly publicised case report of retinal damage reported in the literature. It was reversed, and there are experts who have commented that it was an unusual clinical presentation. So there is some concerns about safety, and there's obviously concerns about the rebound effect, but this does appear to be a very powerful treatment for myopia control. If you'd like to learn more about red light therapy, we've got a lot of articles about it on myopia control, science reviews and clinical articles, including Q&As with practitioners who are using them. And we've enjoyed finding all sorts of stock images with red in them for the backgrounds of these, so they're easily identifiable for you. Now, if you'd like to learn more about specific articles, specific technologies, then there's lots of information available to you on myopiaprofile.com, and I'll just show you how to navigate it. From the home page, if you go to the Knowledge Center, which is that drop-down tab that you can see in the middle of that screenshot there, you can have a look at the clinical articles and search by topic or use the search field, but also I want to point you towards the Myopia Control Product Compendium. And this is where, for a specific myopia control intervention, you can access everything we've ever written on it, whether that be science reviews, clinical articles, sponsored content, non-sponsored content, all within that element there for that treatment. So if you really want to delve into understanding a particular treatment further, that's the place to really go to find everything we've written on it. I hope you've learnt a lot about new technologies for myopia control, and thank you for listening.